Welcome to our channel. Today, we're tackling a critical and complex topic that affects millions worldwide: infections in decompensated cirrhosis, pathophysiology and management. In this video, we'll delve into the pathophysiological mechanisms that make decompensated cirrhotic patients susceptible to infections, how alterations in the gut barrier and microbiome contribute to this increased risk, the role of immune dysfunction in the progression and severity of infections, diagnostic challenges and the importance of early detection, management strategies, including antimicrobial stewardship and emerging therapies. Whether you're a resident, a practicing clinician, or a healthcare professional looking to deepen your understanding, this comprehensive overview will equip you with the knowledge to improve patient outcomes. If you like our content, don't forget to like, subscribe, and hit the notification bell icon so you won't miss any of our upcoming educational content. Prevalence and mortality of cirrhosis. High prevalence of advanced liver disease. 2.8% of civilian U.S. adults show evidence of advanced liver fibrosis. Approximately 0.27%, around 633,000 individuals, have cirrhosis. Significant mortality rates. In 2020, the CDC reported 57,000 deaths due to cirrhosis. Indicates a nearly 10% annual fatality rate among cirrhotic patients. Acute on chronic liver failure, ACLF, severe hepatic decompensation leading to liver and non-hepatic organ failure. Mortality rates for ACLF can reach up to 50%. Impact of systemic infections and sepsis. Commonality of sepsis in cirrhosis. Occurs in 5% to 20% of hospitalized cirrhotic patients. Even more prevalent in those with ACLF. Bacterial infections as precipitating factors. Frequent cause of organ failure in cirrhosis. Most common trigger for ACLF. Nearly 50% of cirrhotic patients with bacterial infections develop ACLF during hospitalization. Multidrug-resistant organisms, MDROs, up to 34% of infections in cirrhosis are due to MDROs. MDROs are associated with increased mortality. This image depicts the pathogenesis of bacterial infections in cirrhosis, highlighting the role of cirrhosis-associated immune dysfunction. 1. External factors. External factors such as malnutrition, alcohol use, frequent antibiotics, proton pump inhibitors, and recurrent hospital admissions with invasive procedures increase the risk of bacterial infections in cirrhotic patients. 2. Intrahepatic abnormalities. Architectural changes in the cirrhotic liver, such as sinusoidal capillarization, decreased production of pattern recognition receptors, and reduced synthesis of acute phase proteins, impair the liver's immune surveillance capabilities. Kupffer cells, the liver's resident macrophages, have impaired phagocytic function, reducing the liver's ability to clear pathogens. Pathogen-associated molecular patterns from injured liver cells further activate immune responses through immune cell signaling pathways like PDL1. 3. Systemic circulation. Neutrophils show increased activation but decreased phagocytic activity and chemotaxis, impairing their ability to fight infections. Monocytes show increased activation markers, HLA Doctor, CD80, CD86, but reduced pathogen clearance. T cells are persistently activated, secreting higher levels of interferon gamma, but also demonstrate immunosuppression in advanced stages, especially in acute on chronic liver failure, ACLF. Other immune cells like B cells, NK cells, and mate cells show decreased activity or frequency, contributing to immune dysfunction. 4. Progression to ACLF. In patients with ACLF, these immune dysfunctions worsen, leading to excessive levels of pro-inflammatory cytokines, chemokines, and endothelial activation markers. Increased immunoregulatory cell subsets, like MERTK-expressing monocytes, further contribute to immunosuppression, increasing the risk of life-threatening infections. The table summarizes immune dysfunction in decompensated cirrhosis and its worsening in ACLF. Neutrophils, impaired phagocytosis and chemotaxis, further decreased migration and metabolic reprogramming in ACLF. Monocytes, increased activation but reduced function. In ACLF, they show decreased antigen presentation and increased immunosuppressive subsets. T cells, decreased frequency and impaired antigen presentation. ACLF shows higher expression of checkpoint inhibitors. B cells, NK cells, and mate cells, decreased activity or frequency. Systemic inflammation, elevated acute phase proteins and cytokines, which worsen in ACLF. Intrahepatic changes, Kupffer cells show decreased phagocytic function, and architectural changes impair immune surveillance further. This illustrates the progressive immune dysfunction from cirrhosis to ACLF, increasing infection risk. This image illustrates key changes in the gut barrier and microbiome as cirrhosis progresses from a healthy state to end-stage liver disease. 1. Healthy gut barrier. Intact microbiome and mucus layer. Provides defense by preventing harmful microbes from accessing the epithelial barrier. Intact epithelial barrier. Tight junction proteins like claudin, occludin, and ecadherin maintain epithelial integrity. Low pressure portal circulation. Healthy circulation supports normal barrier function. 2. Cirrhosis progression. Altered microbiota. Decreased diversity of beneficial bacteria and an increase in pathogens like Enterococcus. Short-chain fatty acids, SCFA, also decrease. Impaired fecal bile acid profile, alters gut function and barrier integrity. Bacterial translocation. Weakened tight junctions lead to the movement of bacteria from the gut into the bloodstream. Increased gut permeability, resulting from impaired junction proteins and compromised barriers. Portal pressure and vascular congestion, increases further disrupts barrier function. 3. End-stage liver disease, increased risk of infections. Patients experience conditions like spontaneous bacterial peritonitis, SBP, infections, and sepsis due to impaired gut defenses and bacterial translocation. This visual underscores the critical role of the gut barrier and microbiome in preventing infections in cirrhotic patients, with their impairment significantly increasing the risk of bacterial infections. Diagnosis and prognosis of infections in cirrhosis. 1. Types of infections in cirrhosis. High morbidity and mortality, occurring in 32% to 40% of decompensated cirrhosis patients. Common infections. SBP, 20% to 35%. Bacteremia, 8% to 21%. UTIs, 14% to 41%. Pneumonia, 8% to 17%. Causative organisms. Gram-negative, e.g., E. coli, Klebsiella, and gram-positive bacteria, Staphylococcus aureus, Enterococcus. Fungal infections. Less common but severe, especially in nosocomial settings. MDROs, increased mortality and frequent in nosocomial infections. This flowchart outlines the evaluation, diagnosis, and management of infections in patients, particularly focusing on cirrhotic patients. Here's a brief explanation for each section. 1. Presentation. Evaluation of infections begins with identifying symptoms that may be localizing, like abdominal pain, cough, shortness of breath, or generalized, like fatigue, fever, weight loss, confusion. Even in the absence of these symptoms, concerns such as impaired liver function, e.g., ACI, encephalopathy, warrant further evaluation. 2. Clinical evaluation. Baseline tests include CBC, CMP, blood cultures, urine analysis, and paracentesis if needed. Additional tests based on presentation include chest X-ray, sputum culture, PCT, CT scan, and abdominal ultrasound. 3. Diagnostics. If non-infectious etiology is identified, treat the underlying cause. If there is a high infection concern, empiric antibiotics are started, considering risk factors for MDROs. 4. Management. If clinically improved and cultures are negative within 24 to 48 hours, antibiotics are discontinued. If no clinical improvement and cultures are negative, further workup is recommended, like repeat blood cultures, non-infectious re-evaluation. If the source of infection is identified, antibiotics are tailored to the specific pathogen, with treatment duration minimized. 5. Future considerations. Serum biomarkers and molecular diagnostics may help differentiate infectious versus non-infectious causes. These tools can aid in early de-escalation of broad-spectrum antibiotics, reducing unnecessary exposure to antibiotics. This algorithm emphasizes early identification, targeted antibiotic use and its stewardship. Management of infections in cirrhosis. 1. MDROs and antimicrobial stewardship. MDROs are present in 34% of cirrhotic infections, with Asia having the highest rates, 50%. Risk factors include prolonged antibiotic use, recent invasive procedures, and healthcare exposure. Empiric antibiotics are common but should be de-escalated if cultures are negative within 48 hours to avoid MDROs. 2. Albumin use. Proven benefit in treating SBP when combined with antibiotics, reducing mortality and acute kidney injury. No clear benefit in non-SBP infections, and the role of long-term albumin remains debated. 3. Empiric antibiotic use in ACLF. Often continued for 7 days, but half of the patients may not have infections, contributing to MDRO risk. Early de-escalation based on clinical improvement and negative cultures is recommended. 4. Advances in diagnostics. Rapid molecular diagnostics, like MRSA PCR, can reduce unnecessary broad-spectrum antibiotic use. Serum biomarkers may improve infection identification and antibiotic de-escalation. 5. Immunomodulatory strategies. Emerging therapies targeting immune dysfunction, including albumin's immunomodulatory properties and immune receptor blockers, are under investigation but need further research. 6. Targeting the gut microbiome. Fecal microbiota transplantation shows promise in reducing infection risk, but larger trials are needed. This table highlights therapeutic strategies targeting various immune and gut-liver pathways in cirrhosis. 1. Toll-like receptors. Adjuvants like TLR7/8 restore immune function and antimicrobial activity. 2. Albumin. Beyond its oncotic properties, albumin has immunomodulatory effects by reducing circulating cytokines and restoring macrophage function. 3. Cytokine blockade. Blocking cytokine receptors to reduce inflammation, but associated with adverse effects such as increased infection risk. 4. Stem cells. GCSF mobilizes stem cells, however, results are controversial, and stem cell therapy is still under investigation. 5. MERTK receptors. Blocking MERTK restores monocyte function and reduces immunosuppressive cell subsets. 6. Checkpoint inhibitors. Anti-PD-1, PD-L1 agents restore phagocytic activity in macrophages, with promising early results from cancer immunotherapy models. 7. Gut-liver axis. FXR agonists improve gut barrier function and reduce bacterial translocation in animal models. These emerging therapies offer potential for targeting immune dysfunction and improving outcomes in cirrhosis, but further research and trials are required to confirm efficacy. This diagram presents a research agenda focused on understanding and improving the pathophysiology, diagnosis, and management of infections in cirrhosis. It highlights key unknowns in these areas and suggests avenues for future studies. By addressing these unknowns through dedicated research, we can advance our understanding of infections in cirrhosis, providing clinicians with the tools and strategies to better manage this vulnerable patient population. Continuous research and innovation will be essential in achieving better patient outcomes and reducing mortality in this critical area. Thank you.